We've been using the light adjustable lens since August 2023. And since that time, I've shared with you several videos sharing our experience with the light adjustable lens and how it works. And I'll share links to those prior videos that we've made in the section below. Now in this video, I want to discuss 4 features of the light adjustable lens, or LAL, and share with you, based on our experience, whether these 4 features are truth or hype. Number 1, the light adjustable lens gives an extended range of focus or extended depth of focus that's better than a monofocal lens. Number 2, the LAL gives very minimal halo at night and gives excellent quality of vision day and night. Number 3, if we target the dominant eye to see far and mid with essentially a plano or zero prescription, and we target the non-dominant eye to be set for mid and near with a refraction in the range of minus 0.75 to minus 1.25, then those patients will have seamless vision far, mid, and near, and will rely on glasses very little. And then 4th, the light delivery device treatments or light adjustments that we do to change the focusing power of the lens, they're very accurate and deliver LASIK-like outcomes. So with the understanding of these 4 features of the light adjustable lens, we selected the patients who we felt would be the best candidates to receive the LAL in our practice. Most of the patients who have received the LAL in our practice have been very happy. Of the 4 features of the LAL, we found that the first 2 features have been very consistent and very true and accurate. Features 3 and 4 have sometimes been accurate and sometimes not. So as of February 2024, the time that we're making this video, we found that there are 2 groups of patients who seem to do the best with the light adjustable lens. In other words, these 2 groups of patients seem to be the happiest with their results when they receive the light adjustable lens. Group number 1, it's the patient who wants really good quality vision far and mid, and they're okay wearing reading glasses for up close or near. They want great vision day and night, and they want minimal halo effect. The light adjustable lens hits that mark. Group 2, it's the patient who, before they've had surgery with the light adjustable lens, they've experienced monovision, where they have had one eye, let's say their dominant eye, see far, and their non-dominant eye see near, and their brain has proven the ability to integrate the unequal or disparate images, and they can function far and near without glasses using their monovision that was either surgically induced with LASIK in the past, or they were born with natural monovision, or they had monovision when they wore contact lenses. These patients seem to do great using the light adjustable lens, but they have to have had the experience successfully with monovision prior to receiving the light adjustable lens. One of the strengths of the light adjustable lens is image quality. So for patients who want excellent quality vision far and mid, they don't mind wearing reading glasses, the LAL is outstanding. And in the past, for patients who wanted good far and mid-range vision and they didn't mind wearing reading glasses, we would use the Vivity lens. The Vivity lens is good. I would say the quality of vision with the Vivity lens is not as good as the quality of vision using the light adjustable lens. I would recommend against using the light adjustable lens in patients who have an expectation to see far, mid, and near without glasses, and they've never experienced monovision in the past. If you've never experienced monovision in the past, there's a 50% chance that you won't like the unequal vision that is created by monovision, even with the light adjustable lens. Which leads me to our patient in this video. I'm going to share with you her story from when we first met and each visit during her visual journey to achieve what we call 20 happy vision. Our patient is a 61-year-old woman who initially came to see us on December 14th, 2023. She wears progressive glasses and on occasion multifocal contacts and wants to improve her vision so she doesn't have to rely on glasses. Her vision without glasses is shown, and her refraction is shown with a best corrected vision of 20/20 from each eye. She's hyperopic and has visually insignificant cataracts. She wanted to see her best with the light adjustable lens. Importantly, she tried monovision contacts in the past and did not have the best experience. So we discussed how the light adjustable lens works, its strengths and weaknesses, and informed her that she might experience a monovision type outcome with the light adjustable lens. On December 20th, she underwent bilateral same-day premium lens replacement and received the light adjustable lens to both eyes. We targeted a post-op refraction of plano for each eye. 3 weeks later, on January 12, 2024, her uncorrected vision was 20/20 far away from each eye, and she couldn't see very well up close. Her refraction was at or near plano. Her exam was normal, so we did our first LDD treatment to give her better binocular mid and near vision that we demonstrated using trial lenses that she would hold in front of her eyes to test drive her vision in our office. The LDD treatment number 1 was to make her a little bit nearsighted on her right eye and about a -1 on her left eye. She liked this vision when we demonstrated this refractive result with the trial lenses that she held in front of her eyes in our office. She returned 1 week later on January 19th, 2024, and her uncorrected vision was as shown. She could see mid and near, but she had lost her ability to see far away. Her refraction was -1 on the right eye and -1.25 on the left eye. On this visit, she reported that for her right eye, her far and near vision were bad, but her mid-range vision was good. For her left eye, her mid and near vision were good, but the far vision was blurred. So the LDD treatment did not result in the intended refractive result. Lesson learned: LDD treatments do not always deliver the intended refractive outcome. On January 19th, 2024, she underwent the second light delivery device treatment to the right eye to bring the right eye from a -1 sphere to plano to improve her far vision from the right eye. On January 24th, she returned for a follow-up exam, and her vision was 20/20 from the right eye and 20/50 from the left eye. Her refraction was close to plano on the right eye and about a -1 on the left eye. Her exam was normal, her cornea was clear, and there was no posterior capsule opacification in either eye. Subjectively, she was very bothered by the anisometropia or difference in vision between her right and left eyes. Now let me introduce you to our patient Linda, who was kind enough to share her experience with us. So Linda, you had light adjustable lens to both eyes December 20th. You had same day bilateral surgery.
Yes, sir.
And you were farsighted, so without glasses you couldn't see far or near, right?
Correct.
December 20th. Right now it's January 24th, right? Yeah.
We're 5 weeks out.
Yeah, 5 weeks out. So when we put in the light adjustable lens, you could see far away and mid-range, but you couldn't read very well.
Correct.
And that's normal. And then we did an adjustment and we brought in your near vision better, but it took your far vision away.
Correct.
And then we did a second adjustment to the light adjustable lens and made your far vision better from your right eye and made your left eye about a -1.25 of nearsightedness. So as of today, you're basically in focus far away from your right eye, you're nearsighted on your left eye. But what bothers you?
Well, the monovision number 1,
Yeah.
that bothers me because I've had a constant headache when I'm doing work. That's number 1. Number 2, when I'm looking far with the far vision 1, I feel a blur, almost like I have ointment in my eye, and I can't see clearly, and my peripheral vision on that is blurred.
From your left eye. So when you're trying to drive,
I'm driving.
you have loss of peripheral vision from your left side.
Yes, sir.
Got it.
And then on the one that's near, when I'm looking near, I have the same symptoms now on the right eye. So when I'm looking near, I have that blurred type sensation, like I have ointment in my eyes and I need to clear it, which I can't. And then that peripheral vision close is blurred also.
Yeah.
So that's one, and I don't know if I'm not adapting, but ever since the adjustment at this time, I feel drunk. I have constant headache when I'm after charting. And then I don't know if it's depth perception I'm not used to, but the vision doesn't correct well enough for me to do simple surgery, simple procedures.
And you do what kind of work?
I am a PA that works in cardiothoracic surgery at UT Del Med. And so I'm in the OR half the time, and I'm in the cardiovascular ICU managing patients the other half of the time. And so while in the operating room, I first assist on all open heart surgeries like cardiac bypass. I harvest all vessels and help close and cannulate and do valve. I first assist on valve surgeries. We put in mechanical circulatory devices as heart mates and do transplants.
And right now your near vision isn't quite good
Not
enough.
at all.
Yeah.
So normally I have to use the loupes, the magnifying glasses that surgeons wear to operate, but I can't see out of them because my vision is not corrected well enough, which I know that could be remedied by putting a prescription in them until this is.
Right.
But the two eyes that don't coordinate, it makes it hard. I feel like my depth perception's off.
Got it.
And I don't see clear enough. Even with this eye, I can read, like 20, 10 or something. I don't see clear enough doing procedures that's safe.
Okay, got it. So our plan is actually to remove, so your right eye is your far eye, your left eye is your near eye, but the imbalance is distracting. So our plan is to work on your left eye, remove the light adjustable lens, replace it with a PanOptix lens. We're going to do it next week. And then the goal is that after you have a PanOptix in your left eye and we leave the right eye alone, both eyes will see far. You'll read from one eye. Your loupes will work better because you won't have the imbalance. Correct.
The also imbalance, I have imbalance intermediate.
Yeah.
Too, and I was hoping that would jive more as they did this, but I don't like it.
And we'll see how it goes. After you give us feedback on how you're seeing after the lens exchange on your left eye, we'll decide what to do with the right eye.
Sounds great.
Thanks. That's it.
Our patients are typically sedated with 10 milligrams of Valium to help them relax and stay calm during the surgery. We use lidocaine drops on the eye surface, then create a 1 millimeter incision through which we instill lidocaine into the eye to allow the patient to have their surgery without experiencing any pain. The anterior chamber of the eye is then filled with OcuCoat viscoelastic. The original primary incision created on December 20th, 6 weeks ago, is then reopened using a Donnenfeld spatula. Helon GV is then instilled into the anterior chamber. Then, using a Donnenfeld spatula in my left hand, I lift the anterior capsule edge upward away from the lens optic to create a space through which we infuse Helon GV to viscodissect the lens implant from the lens capsule. A Connor wand is then used to elevate the lens implant from the capsular bag into the anterior chamber. The lens is then rotated into a position that allows us to easily grab it with microforceps, then bisect it using IOL cutting scissors. The LAL has a few properties that we notice when we try to remove it. Number one, the lens material is more slippery than acrylic lens implants. So when we grab it with forceps, it wants to squirt away from the forceps. Similarly, when we use our micro scissors to cut the optic again squirts or moves away from the scissors. So we have to be more careful when cutting this light adjustable lens inside the eye than we would be with an acrylic lens implant. Number two, since this lens has been treated with the light delivery device to induce more myopia, we notice that the optic seems to be thicker than a typical optic in the middle of the lens. Number 3, when we remove the bisected optic and haptic, we discover that the haptics of the light adjustable lens are very easily dislodged from the lens optic. Based on the haptic optic junction of the light adjustable lens, I would not recommend any surgeon use the light adjustable lens for intrascleral haptic fixation, as the lens would not be stable due to the weak attachment of the haptics to the LAL optic. Both haptics of this LAL separate from the optic during a relatively straightforward explantation. We then insert the PanOptix lens, then remove the viscoelastic from behind and in front of the lens implant. Center the lens properly, then seal our incisions to make sure they are watertight. Here's our patient the day after this intraocular lens exchange procedure. She has the LAL in her right eye and the PanOptix in her left eye.
So you had the light adjustable lens removed from your left eye
Yes.
and a PanOptix put in yesterday.
Correct.
Before, with the light adjustable lens, which was set for about a -1 on your left eye, what bothered you about your vision?
Because they are monovision,
Yeah.
it bothered me because when I looked close, this was blurred, and when I looked far, this was blurred.
Got it.
And then distance-wise, or medium distance, I couldn't get in focus with either one of them
Got
at
it.
the same time. And so when I'm looking and working, I felt drunk and I had a headache.
Now, have you ever done monovision before with like contact lenses?
I tried that once.
And how did it work out?
I didn't use them. It was, yes.
Good. So this points out that I think going forward, if somebody hasn't had successful monovision, I'm probably not going to offset it with the light adjustable lens. And then, so now you have a PanOptix, and now both eyes can see far away.
Yes,
How's that?
I'm loving it. It's great.
Okay, you don't have they're not fighting one another.
They're not fighting that at all.
And then reading vision, how's your reading vision now?
I can read well up close.
You were saying you can read.
Yes, I can read my phone, where before, even with the other one set,
Uh-huh.
I had to keep my phone out.
And your watch, you can read your
I
watch?
can read the actual name of my watch, not just the numbers, but I can read the small thing. Oh, can be underwater up to so many feet.
Okay, so can you come here and take a picture of her watch so people can appreciate the focus on it?
And I haven't been able to do something like that in 30 years.
And then, so now you're faced with a choice to leave it like this, where you have light adjustable lens right, which is for far, and a little bit of mid, and the PanOptix in your left, which is far, mid, near, or have the right eye exchanged for a PanOptix as well, so you have both eyes working together. But can you tell, it's only day one, so there's usually a little, the dust has to settle in the exchange, but what's the quality of vision between your light adjustable right eye and your PanOptix left eye for far away?
Well, right now, the light adjustable lens has a very crisper contrast
Yeah.
than the PanOptix
Yeah.
today.
And that'll probably be, it'll probably improve on the left eye, but you'll still probably notice a little less contrast on the PanOptix than the light adjustable lens. So the rule is you trade quality of vision for range, but now the PanOptix has a lot more range, just a little less contrast.
Correct.
Okay, so you're on the schedule for Monday exchange right eye. That's 5 days from now. If you change your mind, we'll leave you alone. If you say, and you're comparing and you kind of test your work environment and you're still bothered and you want your right eye to work like your left eye, we'll do it.
Okay, sounds great. In fact, I'll go home and get on the computer as far as that part today.
Yeah, test it. If you want, and if you want to wait, if you go, I need more time to think about it, well, wait. No need to hurry and do anything.
Okay, and so if I do wait or decide to keep, then we have to lock this in, correct? Because it's not locked in.
Once you decide, I'm sticking with what I have, and you stay with the light adjustable on your right eye, I will lock it in.
Okay, sounds like a
But once
plan.
you say, no, I can't, I like my left eye too much, I want both eyes to match, it's your call, I'll leave it up to you.
Yes, sir. I probably will make a decision no later than Friday afternoon.
That's fine, thanks.
Thank you.
We saw you yesterday. What did you notice and what did you decide?
So you said go and test out. So I actually pulled out the computer, started working on that.
Yeah.
Right, and I noticed no visual difference between the two eyes reading.
Okay.
Up close. I didn't have that cover like I did with the distinct monovision.
Yeah.
Then I went out for a drive also at night. I noticed that if I did close the LAL eye, I could see the little halos, but with both eyes open, did not appreciate halos at all, and my distance vision between the two of them was fantastic. I didn't feel that nauseous from the monovision at all. I'm actually very happy with it.
So this combination, LAL right, PanOptix left, you're good.
It works, yes, it works for me. I'm good. I even put my loops on for work and check my distance when I do things, and sutured up a banana to make sure I could see and had good depth perception and no issues whatsoever. I'm smiling. See, I'm very happy with this.
Perfect. Okay, so we're gonna lock it in. We're gonna lock the right LAL in.
Yes.
Make it permanent.
Correct.
Awesome, thanks. So just tell me what you said about
Well, the salient point is when I had both LALs, correct, and this was a little bit shorter in distance, it really bothered me and I was nauseated, had a headache. Now that I have the PanOptix and the distance is the same, although the quality is a little bit different, when I'm looking at both eyes, the right eye takes over and gives me the quality of the LAL without noticing any difference between the two.
Awesome.
You know, yes, it's seamless. I can't even tell. But this one dominates this one. Even when I'm driving at night, which I did last night, I could see halos a little bit around lights when I close the LAL eye. When I open both of them, halos are gone.
Beautiful. 22 seconds to go. So what are the lessons that we learned from this patient? Number one, the combination of the PanOptix in one eye and the light adjustable lens in the other can and does work very well. So this patient had ultimately outstanding far vision, minimal halo at night, outstanding mid-range and near vision, and they were essentially able to function for most tasks without any glasses whatsoever. And number two, not all patients will tolerate the blended vision or monovision using the light adjustable lens, where we set one eye to see far and mid and the other eye to see mid and near. Our patient did not like that anisometropia or difference in vision between her two eyes. Her eyes seemed to be fighting one another with that type of vision. So the rule of cataract and lens replacement surgery, that there is no perfect lens implant, has been true and remains true today and will likely remain true for the foreseeable future. The best lens is the lens that you were born with and that you have until the age of 40. Thankfully, our patient is happy with her visual outcome. So thank you for your time in watching this video. I hope it was useful. Have a wonderful day, and I'll see you on the next one. Bye-bye.